as we have mentioned, one of the provisos or one of the assumptions when doing motion capture modeling and modeling is that each segment is assumed to be rigid. And as we know, the foot is not such a rigid structure. In fact, the plug-in gait model, which models the foot as a rigid segment, is not so accurate in that respect. So over many years, researchers have come up with various methods of creating foot models in order to represent segments of the foot. The Oxford foot model, which was created at Nuffield Hospital in the UK, represents the hindfoot, forefoot, hallux, and shin, and any movement between these segments. And the Istituto Rizzoli foot model, which is also known as the Leardini model, represents the motion of the calcaneus, the midfoot, the forefoot, and the hallux, also the shin, so we can see that there is an extra segment. Also, other models include the Ghent foot model, or perhaps the most comprehensive models of them all is the Glasgow Maastricht foot model. The authors claim that they have managed to model each and every individual bone of the foot. A model that represents foot motion much better than the plug-in gait model or the conventional gait model is known as the Oxford foot model. As one can see, when comparing one foot with the plug-in gait to the other foot with the Oxford foot model, in the latter model there are many more markers. That is because, as we know, the foot has many segments and segmental motion is quite difficult to track and analyze. So the Oxford foot model is one particular model that represents and captures motion in the calcaneus, in the forefoot, and the hallux, also in relation to the shin. So with the calcaneus, with the Oxford foot model, we can actually analyze movement and motion that occur in each body plane of the calcaneus relative to the forefoot, and also of the hallux, and all three in relation to the shin. Whereas with the plug-in gait model, we can only measure dorsiflexion of the whole foot. And as we know, movement in the sagittal plane of the foot does not only occur at the ankle joint, but can also occur at the mid-tarsal joint. And so basically the plug-in gait model should not really be used when we want to focus specifically on the foot. So following data acquisition, the next step is to see the integrity of the data, and using special gait analysis software, we must look at various aspects of our patient's walk, and we must look at all the outputs that are given by the software. For example, here we see the lab, the reconstruction of the lab with our patient walking onto the force plate at the moment, also the layout of the cameras. If we move on to the other screen, we can see the visual image of the patient walking. We can look at an overlay of a 3D representation of the floor and the model onto the patient's video. Also, we can obviously slow down the images, and we can control them as we want. Besides this, here we can look at the EMGs. We've got EMGs of the tibialis anterior and the gastrocnemius in order to see how muscle activation is occurring. This will give us a visual representation of what is going on. However, if we look at the outputs, then we can create various charts that will give us an idea of each segment, how it is functioning. For example, here we are looking at pelvic tilt. We can see pelvic obliquity and pelvic rotation. The same thing goes for the hips, hip angles, hip flexion and extension, hip abduction and adduction, and hip rotation, and knees, also knee flexion and extension, knee abduction, adduction, and knee rotation. Also, we can look at the ankle angles, dorsiflexion and plantar flexion mainly, and also abduction and ankle rotation. Being a foot model, we can also see, for example, the forefoot to hindfoot angles as they are occurring. Also, this software gives us things like cadence and gait timing analysis. So looking at the various graphs, we can now compare these with normative data, which is available in literature, and from there we can see which segment of the patient's lower extremity, for example, looking at the knees, we can know whether the knees are functioning properly or not, so that we can then address the treatment that we are going to give to our patient, whether it is through some kind of surgical intervention or medical intervention through mechanical intervention like orthosis and so forth.
Normative data is very important for any gait analysis that is done on patients, because without normative data we would not know what is really normal or not. I will use this paper as an example. This paper compared normative reference data from different gait analysis services, and basically they found a high degree of consistency between data from two highly regarded gait analysis services, meaning that the two different labs more or less had the same normative data, which is very encouraging for us. The idea here is to show you these graphs here, which are the normative data for the pelvis, for the hip, for the knee, and for the ankle. So in each plane, okay, we see that there is the mean value and the standard deviation, which is to make up for any variability as people walk, because obviously people vary and we will not always have exactly the same results. So we have pelvic tilt, pelvic obliquity, pelvic rotation, hip flexion, hip adduction and hip rotation, knee flexion here, and ankle dorsiflexion. Also here we have foot internal and external rotation. Basically, once we have data that we have acquired from our gait analysis, this is the normal data that we can compare to determine which part of the lower extremity is not functioning correctly. That way it will help us to reach a better diagnosis, and it will show us not just subjectively but having objective measures what is necessary, and whether our treatment, if we do another gait analysis later on, whether our treatment has been successful or not.